Hello, everybody. I can actually say good morning, good evening, and good afternoon. Welcome from the Winglet studio in Munich. My name is CHRISTOS KOUKOS. I'm happy to be here today with Andy VOSS. Today's topic is new trends in anterior shoulder instability. And as you've seen, we've brought 3 orthopedic platforms from all over the world together. Winglet, of course, from Europe, Shoulder Planet from South America, and OrthoTV from India. Of course, we have an outstanding faculty. You'll see, we'll watch in a bit their lectures. And of course, at the same time, we're really glad that we have in the co-moderation from the other part of the world, South America, SERGIO ROWINSKI from Brazil and Daniel MOYA from Argentina. Andy?
Also, hello from my side and welcome to this outstanding and fantastic event. Before we start with the presentations, I want just to give you a few information about the platform and how you can interact with us and with the team. So first of all, we have several patronage on this event. We have the ISACOS, the ESCA, the AGA, and also the Asociación Argentina de Hombro y Codo and the Sociedad Latinoamericana de Hombro y Codo, and also the International Board of Shoulder and Elbow Surgery. This event is also accredited with 6 CMEs, which you can get after the post-live productions. We want also to thank our sponsors because this event is totally free for everyone to watch. And of course, you should be part of this event. So on your right side on the screen, you see a Q&A box where you can ask questions to our faculty, and we'll moderate the questions after the blocks, the first part and after the second part. But we also have live voting. That means during the talks, you have the possibility on the right box to answer the questions, which will also be moderated by us after the presentation of each instructor. This being said, we don't want to talk too much, and we want to start with our first presentation. We are more than happy to have Sugaya from Japan with us today, who will talk about arthroscopic soft tissue bone and bankhead repair with augmentation. This is the way to go. Hiro, thank you for your time to join this event at late night. I think it's midnight at your time. Before we start your presentation, we want to start with our first live voting, asking the question, which factor is the most contributing after adding rotator interval closure to soft tissue bankhead repair? Hiro, thank you.
I'd like to thank Dr. VOSS and Dr. KOUKOS for inviting me to this wonderful event. This is my disclosures. Soft tissue bankhead, many surgeons' perception is anatomical procedure, technically not demanding. However, outcome is unreliable, and especially in collision contact athletes. And indicates, therefore, indications are limited to minimum bone loss and a low demand patient like ISIS score less than 3. And more than 6, it's a contraindication. And this year, we have published a very interesting, important study. This is arthroscopic soft tissue stabilization with selective augmentation for traumatic anterior shoulder instability in competitive collision athletes in the American Journal of Sports Medicine. So let me introduce this paper a little bit. And between January 2012 to March 2017, we had 150 shoulders in consecutive 150 shoulders in a consecutive 135 patient collision athletes with shoulder instability. We excluded the patient more than 40 years old and also less active athletes. So therefore, we have 140 shoulders in 127 athletes. And we also excluded the 2 patients because we had bony procedures because of the severe bone loss without the bony fragment and also capsule quality. So therefore, we had a 138 patient and 138 shoulders in the 125 athletes. And we also excluded the 35 patient because we lost follow-up. So therefore, the patient subject included the 130 shoulders in the 100 athletes, collision athletes. and the 82 follow-up rate was 82%. So the subject, and regarding glenoid morphology, 64% present bony buccal region. And also, interestingly, 53% had off-track region preoperatively. And regarding the instability severity index score, we had 34 patients had a more than 6 ISO score, which is exactly totally a contraindication of the arthroscopic soft tissue repair. So the outcome was we had only 4% recurrence for patients, which is 3.5% of recurrence, and that 93% of patients returned to pre-injury level of competition. So why so successful? I think there are 3 factors. Number 1 is ligament retensioning. Number 2, rotator nerve closure as augmentation. Number 3, Cusack's limb research as also as augmentation. So the soft tissue buccal repair should be a capsule, arthroscopic capsule assist. This is not just a simple labrum repair. So therefore, we normally release the labrum until all the way down to 7 o'clock, and also we remove the face of the inferior face of the glenoid at the cartridge, and insert the 3-4 anchors and the place sutures like that, and tie the knot. And this is the totally inferior glenohumeral ligament retensioning procedure. This is actually a video of the right shoulder. This is a Cusack's region, and so this is a view from the anterior banquet region, present only 2 to 5 o'clock, and no haggle region. But in this case, normally we do release the labrum from all the way down to 7 o'clock. Even if it looks, inferior portion looks normal, we use scissors like this, and then release the labrum until this labrum becomes completely free from the labrum, from the glenoid. And also we remove the cartridge at the face of the inferior glenoid in order to maximize the tissue healing. This is after release. And this is a view from the anterior after release. And we use 4 anchors and the sutures like that. And this is after repair. This is a view from the anterior. Okay, the bony buccal region is normally a chronic region. So fragment becomes smaller with time. However, fragment is connected firmly to the labrum. So that's why we already published a very nice outcome after arthroscopic osseous bony buccal repair back in 2005 and 6 in JBJS. And also, recently in 2015, we also published a longer-term outcome study, which was 38 consecutive shoulders, more than 15% of glenoid bone loss, regardless of the fragment size, and the average pre-op bone loss was 22%. However, we achieved the excellent remodeling and bone union in the longer-term follow-up, and the recurrence rate was only 2.6%. So the bony buccal region in high prevalence in the collision athletes, and also glenoid tract, but actually in our study, off-track region was seen in 53% of patients. So normally this is not the contraindication of a soft tissue banquet, but I think bony buccal repair worked for these off-track shoulders. Oh, let's look at the rotator cuff and glenohumeral joint capsule relationship. These are very anatomically very close relationship. And normally the rotator cuff muscles lines the glenohumeral joint capsule just outside joint, glenohumeral joint. And also this is a study investigating capsular thickness. They found that the inferior pouch of the glenohumeral joint capsule is the thickest because there's no lining rotator cuff muscle outside the joint. So this is very interesting MR arthrography of the normal shoulder. You see, it looks like that. This is sizal view. So this is a picture. This is also a picture. And interestingly, you can see the inferior pouch capsule looks very thick, but no surrounding rotator cuff muscles outside. So that's why the capsule is thick. But there's an opening of the glenohumeral joint. This is interval. There's no surrounding rotator cuff muscles. And also capsule looks capsule is normally very thin. So why don't we close this opening? So this is my rotator nerve closure procedure. See, normally I incorporate the subscap tendon to the subtendon to the rotator nerve closure, and after pressing the suture to the subscap, lift nylon suture. Then I bring the arm to the maximum external rotation and place the suture and retrieve the nylon suture to the high strength suture. So I repeat the same process twice. I normally use 2 or 3 high strength sutures for closing rotary interval. So this procedure, if you look at from the Brasil side, this is a procedure closing the both root of humeral ligament, which originates from the base of the carpal to insert to the both subscap and the supraspinatus with the maximum external rotation. So by doing this, maybe we can reduce the good humeral joint volume. Then we can induce biofeedback through the restored proprioception by ligament retention, which is back-up repair. So the other augmentation is Axe repressors. Actually, Gene Wolf started doing this for the engaging his axe region. He presented the paper to the ARA meeting back in 2004. And he originally started doing this for the arthroscopic capsular tenodesis for the glenoid bone loss and the large his axe region. But we are now using the as an augmentation for young, high-risk collision contact athletes. So this is a posterior cuff structure. This is the infraspinatus tendon. This is the intersminor minor tendon. But when we look at this portion from the skull, it looks like this. Between 2 tendons, there's a muscle directly going into the capsule. So that's why we can distinguish the infraspinatus and intersminor very nicely under the direct visualization. This is my modified Hughes-Sachs repressor in the V-shape position. First, we insert the anchor like this. Then we retrieve the suture to the bursa. Then we see this border this structure between the infraspinatus and teres minor. And we try to insert the sutures to this line, dotted line, under direct visualization in the bursa. And after placing suture like this, then we proceed to buncred repair. Then we proceed to buncred repair and rotary interval closure with the maximum external rotation. And finally, we tie the repressor suture like this. This is the after repair. My personal experience is I'm quite satisfied with soft tissue buncred. More than 95% of my series arthroscopic buncred or bony buncred repair with or without soft tissue augmentation. The rest of 5% of a series I do bone grafting. My indication of bone grafting is only for severe bone loss without bony buncred region in active patient. Thank you for your attention.
Thank you, Hiro, for this great presentation. And now we want to look at our live voting results from our spectators. So, interestingly, we have several answers here. Which factor is the most contributing after adding rotator interval closure to soft tissue buncred repair? And 38% answered dynamic stability through the subscapulars together with the restored proprioception by soft tissue buncred repair was the most clicked in our live voting. So now I want to give the present discussion over to Daniel to Argentina. Hello, Daniel. How are you?
Hello, very well, thank you. Very nice presentation, Hiro. Let's begin with some questions. We have some time for questions. Which is the limit for this procedure when you are planning surgery in a case? When do you decide you will go to a bone procedure or this kind of procedure?
I think my indication bony procedure is very limited, less than 5%. That is the bone loss, severe bone loss of thoracic region without bony fragment. That's my indication. And also the patient activity. If the patient is a little bit older, less active patient, I do soft tissue. But a young active patient without bony fragment, severe bone loss of thoracic region, that's my indication of bony procedure.
Good. And you said that soft tissue buncred is unreliable for collision athletes. Do you include open buncred or you were speaking about arthroscopic Bankart?
Or arthroscopic.
Okay, okay. Because we used to perform for the last 25 years the application of the rotator interval, and we stress a lot how we deal with the capsule when we perform an open Bankart. And we feel that we have a very good control of the application by the open way. What do you think about comparing the chance that you have to applicate the capsule with the arthroscopic procedure or the open? Have you experience in the open Bankart proceeding with the application, open application?
Actually, I did the the beginning of my practice, I did only a couple cases open.
Mm-hmm.
So that was very far away, so I forgot everything. So I'm a 100% crazy arthroscopic guy now.
Good.
So I think the open Bankart plus capsular shift and also the interval closure works very well. I know that. So that's why I try to simulate open capsular shift and the interval closure doing arthroscopic procedure. So the important thing is, I think, the incorporating subscap muscle, subscap tendon is very, very effective. So in order to then by doing that, we can incorporate the outside rotator cuff muscle dynamic stability. So that's why my interval closure, arthroscopic interval closure, is really similar. I think it's similar to the open interval closure.
Thank you very much.
Thank you very much. We will continue.
Thank you very much for this wonderful presentation, and good night, we have to tell you, yeah? Our next speaker is Philippe COLLIN. Thank you, Philippe, for being here with us today and for accepting our invitation. His topic is dynamic anterior stabilization. As we all know, he's developed this together with Letterman. And first, we have to mention our live voting here for this topic as well, regarding the DAS, the dynamic anterior stabilization. You have actually to choose which one of the four statements are right. We can continue with you, Philippe. You can start. Thank you.
So thank you very much for the invitation. Today we are going to speak about something new, which is dynamic anterior stabilization. What is dynamic anterior stabilization? What is DAS? This is the first draw that I did 5 years ago in order to explain my idea. The idea is this one. This is what we do usually with the Latarjet. It means that we take the coracoid and you put the coracoid here in order to have a sling, a hammock effect here. It's exactly the same, but we don't take the coracoid, we take the biceps, as you can see here. So the most important, what is very, very important to remember and to understand is the fact that you have this hammock effect with the Latarjet, and you have exactly the same with the DAS. This is a Latarjet. You think that you will have a good stabilization of your shoulder in abduction and external rotation because you put the inferior part of the subscap very low. And you can see here that you have exactly the same effect with the DAS. So of course, we didn't try it first with the patient. We tried this at the lab, as you can see here. We wanted to know if it was possible or not to do this. And we were surprised to see that it was possible, in fact. So we did a biomechanical study. As you can see here, we've tried to see if it was reproducible and what was the effect of this DAS, dynamic anterior stabilization, on the shoulder. We've published it in the American Journal of Sports Med. And look, this is when you apply 40 Newton of force, then you can see what happened on a native shoulder, what happened when you have a defect, what will happen when you have a Bankart repair, and what happened when you have a DAS. You see that you are better than a native shoulder. Same when you have a lack of bone of 10%. But if you have a lack of bone of 20%, it's not possible because it works too much that you have a posterior subluxation of your head. So biomechanically, it works very well for no bone loss or 10% of bone loss. So we've published after that this technique in arthroscopy. We're going to share a video together. As you can see here, the patient is in bed chair, and the first step is to open widely the rotator interval. You open widely the rotator interval like this. It is an important step. As you can see here, you detach as usual, like for a regular bone cart, you detach your labrum, as you can see here. And you need to go up to 6 o'clock. You need to detach very well all the inferior part, and you need to see very well the subscapularis. After you put a thread into the biceps, it will help you to recognize your biceps in the next step. And you cut the biceps like a regular long biceps tenotomy. The second step, you go on the lateral portal and you take your biceps here. This is a conjoint tendon here. You take your biceps and you put your biceps outside of the joint, and you release here a bit in order to have a good length of biceps. This step is not difficult, not at all. You just need to be very low. So you follow your coracobiceps and you find your biceps. Then you put your biceps outside of the joint, as you can see here, and you prepare your biceps in order to calibrate it at 5 millimeters. In the past, I used to make a big hole, a hole adapted to the biceps, but now I just adapt my biceps to the hole, as you can see here. Then you put your scope on lateral, you make a hole at 5 o'clock in the glenoid, as you can see here, a hole of 30 millimeters, it's enough. You see it very well here. And what you can do, you put, of course, you put a cannula, and then you start to open your subscap like this. You put your camera into the split, and you put a Wissinger stitch, as you can see here. Then you put your scope in lateral. You see here very well your Wissinger stitch, and you make a small hole of 1 centimeter. You take your suture passer here and your biceps. Then you can put your biceps through the subscap split, as you can see here, and it's almost the end of the procedure. You just need to put your biceps into the hole, and with an interference screw here, a swivel lock, you can see at the end that it's done. Then what you can do, it's to we create after a Bankart repair, and you see very well here the hammock effect. This is a post-op X-ray. This is a patient at 3 months follow-up, all range of motion, no apprehension. The post-operative rehabilitation is very regular. It's like a Latarjet, a sling for 10 days, and we start to the rehabilitation immediately. So we operated on 22 patients. There were 7 hyperlax patients, and the raw score play was 62. We have 3 recurrences. It was at really the beginning of the learning curve, the first patient. Now we've done more than 50, and we have no recurrence anymore. There is no lack of range of motion. So the 3 recurrences were really related to the learning curve. And there is a very good effect of what we call the sling effect. It is very, very, very important. I think you have a lot of advantages because there is no risk for the nerve and no risk of traction of the coracoid process. So I published it in 2016 on VMedi. And now our indication are anterior glenohumeral instability with no more bone defect superior to 20%. Of course, if you have an associated slap lesion, it's a perfect indication, and you can use it on hyperlax patients. You have no coracoid transfer, so you don't have the problem with the bone resorption, and you keep the pec minor, which is probably very important for the sport. Because we don't know if we really need a bone graft. It is possible that the Latarjet works more with the sling effect rather than the bone effect. So in my practice, I don't do isolated Bankart anymore. I always do now DAS. I do that for now 5 years. I'm very, very happy about that. So in the past, we used to have Latarjet or Bankart, and now we have something between, which is a DAS. Thank you very much for your attention.
Thank you very, very much, Philippe, for this excellent presentation. So let's go first to the results of the live voting. Let's see what the spectators actually answered here. Regarding to the DAS, so 56%, as we see here, the answer that the principle is to recreate the sling effect of the Latarjet. And then we have the same time 37% biomechanical studies that showed the results are better than the Bankart repair. So for the answers and stuff, I'm gonna give the moderation now to Daniel. Daniel, you're up.
Thank you very much. Very nice presentation, Philippe. I would like to ask you, you said that you use this technique in hyperlaxity. Do you perform any kind of procedure to the capsule? You plicate the capsule?
Thank you, Daniel. So first, thank you for this wonderful meeting. I really enjoyed to be there with you. No, I never do capsule. I never do something on the capsule because unfortunately I did a lot in the past, open or arthroscopic. But I think that after 2 years or 3 years, you have a new capsule, and then whatever you've done previously, you have a recurrence. So now I don't do anything on the capsule. We know that, for example, when you have a frozen shoulder, you have a very, very stiff capsule, and then 2 years after, you have a new capsule, and everything is like before. So I know it's probably not the truth, but I definitely think that doing something on the capsule can work, but not more than 2 or 3 years.
And do you consider that you can control the micro motion of the joint with this procedure?
What do you mean by micro motion?
In patients with, in patients with hyperlaxity, like you know, many of them have some kind of symptoms related to motion in different directions. And in this case, you are putting a barrier in the anterior and inferior side, but what about the posterior?
I understand. Thank you for your question. Perhaps it was not clear in my presentation. In my presentation, when I speak about hyperlaxity, it's a true anterior instability with sign of hyperlaxity. For me, I almost never operate on isolated hyperlaxity, because for me it's not a pathology. It's very difficult to treat, but not as a surgical way for me.
Okay, and finally, we used to say that we have procedures in which we respect anatomy, where we repair anatomy, and we can choose also reconstruction when necessary. Suppose that you get a 17-year-old rugby player that has two episodes of instability. Would you offer this kind of reconstruction for this young person, or would you prefer a repair?
You mean repair a Bancard or a Latarjet?
No. Suppose that there is no bony deficit, that it is just a patient for a soft tissue procedure. Would you directly go forward to the biceps reconstruction?
Yes, definitely, but because we know that isolated Bancards doesn't work very well. And we have the proof, because for now 20 years, we add remplissage, we close the rotator interval, we put that capsuloplasty, because it doesn't work.
You are speaking about arthroscopic Bancard?
Yes.
Okay.
Perfect.
Okay.
Thank you. Thank you to France, and thank you.
Open Bancard, it works, but patients are very stiff after surgery on open Bancard. They are stable because they are stiff.
That's not my experience.
Okay, thank you both of you for the lively discussion, and we want to go to the next lecture, which is presented by Marco MAIOTTI, and it's talking about anterior subscapularis augmentation. Marco, thank you for being with us today, and before we start our presentation, let's go back to the live voting. So which procedure would you perform in a dislocated shoulder of a 20-year-old male with 15% anterior glenoid bone loss? You can see here the answers, and you're more than happy and welcome to answer during our presentation. Marco.
ASO repair addressing the anterior capsular deficiency. The risk factors for arthroscopic Bancard repair failure are capsular tissue deficiency, shoulder hyperlaxity, contact sports, and bony defects. And sometimes we can reach 50% of failure. This is an arthroscopic view of a clear capsular deficiency. You can see, obviously, if you perform a Bancard repair here, we have no good tissue. Talking about hyperlaxity, we can have a general articular hyperlaxity or a general articular hypermobility that is asymptomatic. Shoulder hyperlaxity is acquired or constitutional and can be anterior-inferior. This is acquired shoulder hyperlaxity due to the related to sports gesture, overhead, obviously. We have a constitutional hyperlaxity that belongs only to the shoulder joint and not to other joints. And we have the specific test to detect an anterior-inferior shoulder laxity. The inferior laxity is detected by the circle signs, and usually we have an elongation of the coracohumeral ligament, that is the anatomical structure that is important for reducing the superior-inferior translation of the humeral head. The other test that to detect, to show an anterior hyperlaxity is the Gudan test, as you can see from this slide. And when you reach an external rotation with the arm in adduction more than 85 degrees, we have an anterior hyperlaxity. And we have an anatomic thin and redundance of the anterior capsule and an hypoplasia of the anterior labrum. Studies have demonstrated that capsular stretch after repetitive glomerular dislocation and have suggested that the lax capsule, not the bunker lesion, is the essential lesion that permits glenohumeral dislocation. Another risk factor are contact sports. This is a slide that shows the relationship between the coracohumeral ligament and another important structure for the stability of the shoulder, that is the anterior stability of the shoulder, that is the subscapularis tendon, especially its upper third. When we have a shoulder hyperlaxity, anterior inferior shoulder hyperlaxity, or a capsular deficiency due to multiple dislocation, we have the upper third of the subscapularis tendon has to be lax. This is an arthroscopic view of an upper third of the subscapularis tendon hyperelasticity, and this is a normal subscapularis tendon. So to decide what kind of surgery we have to do after an anterior recurrent dislocation, we have to diagnose very well. We have to do a clinical evaluation, very accurate. We have to inquire the patient about his first dislocation and the age of the first dislocation. We have to do an arthro MRI, and we have to detect the percentage of the bone loss. According to an idea of Lenny Johnson, who stated in 1986 that when you have a poor capsule, you have to involve in the repair the subscapularis tendon. We start to do this kind of technique, and we call the Asa Technique, that is an augmentation of the bunker repair with the upper third of the subscapularis tendon, and we published this paper 8 years ago. We start using this the combination of a tape with a push lock, knotless peak anchor, and then you can use a new generation suture, but obviously we have to use a tape. How to do it? The glenoid bone hole has to be done over the top position of the glenoid edge. The subscap has to be penetrated at least 5 millimeter inferior of its upper border, almost at the same level of the glenoid surface. Here is where to penetrate the tendon. We use the tape because the ASA is a tendon fixation, it's not a capsule fixation. Here is the tendon fixation when we impact the anchor. The bone hole has to be done at 2 or 10 o'clock position, so you can lift up the subscap, reduce the widening of the interval, and lift up even the anterior inferior capsule. This is before and after the procedure. So, some consideration. We believe that the ASA procedure may reduce the coracohumeral ligament length and reduce the capsular volume. This is an arthro MRI study that shows the shortening of the coracohumeral length after the procedure and the closure of the anterior capsule. some biomechanical data in a biomechanical study confirm that that ASA is more effective than single bunker repair in reducing the antero-inferior translation. The recurrence rate of ASA plus bunker repair is equal as the one of lateral J. We published this other article. And another consideration, very important, that ASA acts in the opposite way of the remplissage because pushes the humeral head posteriorly. The remplissage pulls the humeral head posteriorly, so he reduces the pathologic condition of the heel sacs. So no matter where the heel sacs is, if you pull it posteriorly, you reduce the off-track action of the heel sacs, as you can see in these slides. We have mild osteoarthritis after ASA procedure. So you should not be afraid to use the subscapularis tendon for stabilizing the shoulder any longer. This indication, anterior inferior hyperlaxity, capsular deficiency, GBL less than 15%, and inpatient performing contact sports. ASA plus bunker repair represent an effective alternative to the lateral J that could be an overtreatment in many cases. ASA has a triple effect. It addresses the stretched part of the subscapularis tendon that is always lax when there is a bad capsule, restore capsular insufficiency, restore the coracohumeral ligament tension, reducing the sulcus sign, so it will work, very important, without causing external rotation restriction. We published another article in arthroscopy when we showed that external rotation is not compromised. The historical surgeries like Putty-Platt and Max Tuck were dealing with the entire tendon, shortening it and causing a problem to the external rotation. But ASA is a complete different surgery. 4 reasons for why to use ASA: low learning curve, low recurrence rate, low complication rate, a high opportunity for new surgery if there is a failure. This is the result after 5 months. This guy had 6 dislocation. And you can see no limitation of external rotation at all, a good stability. This is another case. It's a champion of diving and of skydiving. No limitation of external rotation, very good result. We published a last article with Badi Savoie and very good results in athletes with shoulder hyperlaxity. And my friend Wentao Zhang in China modified the technique, but with the same philosophy, and he had modified little the technique, but he had very, very good results. When we have a pathologic glenoid bone loss, when the soft tissue repair is not enough, we combine the Asa technique with the bone block. We start doing with the allograft, and since 2018, we are using a xenograft pre-shaped in combination with Asa, and we save time. The procedure is not so long like using a graft from the iliac crest. And this is an arthroscopic view, the bone block, the Asa technique up. And this is 2 years follow-up of one case. You can see that the xenograft is very well accepted to the glenoid neck and very good position. We have done right now more than 30 cases, and we think that it could be a valid option for the bone block procedure. Thank you for the invitation. This is a picture of the last meeting in Athens, and I hope that we can go back like we were before. Thank you.
Thank you, Marco, for your excellent presentation. And so we're looking back to our live voting. Which procedure would you perform in a dislocated shoulder of a 21-year-old male with 15% anterior glenoid bone loss? And you can see 55% answered the letter G and 31% Asa, 32%. So Daniel, going back to you, what is your perspective?
Well, I will just ask Marco, what about the inferior pouch? Because we know that the rotator interval has a very important role in multidirectional instability. Do you perform any kind of procedure at the inferior pouch?
No, I don't do any procedure to inferior pouch. I think that if you lift a little bit up with the tenodesis, the subscap, you can have a closure of the anterior inferior pouch too. So I don't perform any inferior procedure.
Good. Well, we are running a little bit late, so I think we will have the discussion with the questions for the audience later. Thank you very much.
Thank you.
Thank you, Daniel and Marco. We'll skip our Q&As at the end of our session, so we'll have the possibilities for all participants to have answered their questions. So please stay tuned. After the little break, we'll be back with the second part of our session.
Welcome back again, the Winglet studio in Munich. So we can proceed now with our program. And now we have the presentation of my countryman, Manos Brilakis, Remplisas after 10 years follow-up. Before that, don't forget, as always, the live voting. In this case, we have the question, which is your preference for augmenting the classic backward repair in your practice? You have 5 options here. You can answer, pick one of them. And Manos, you can proceed with your talk.
Hello, my name is Manos Brilakis from Ygea Hospital of Athens, Greece. And for the next few minutes, I will speak about the Remplisas and what we have learned after 10 years of follow-up. These are my disclosures, mostly scientific. I would like to thank our moderators for the kind introduction and Winglet for the hospitality. Our subject is the anterior instability and the backward lesion is the essential lesion. However, apart from the restoration of the normal anatomy and the reestablishment of the appropriate tension of the ligaments and the capsule are not sufficient to provide long-term good results, because the recurrence rate is almost 30% and the average in the literature is from 20 to 40%. So beyond the restoration of the anatomy, there are some more prognostic factors that we take into consideration in order to manage these cases. And bone defects are very significant, and these classical articles highlighted the significance of bone defects. Bone defects are very common, and they can be found up to 70% of the patients even after the first time dislocation. And more sophisticated articles shows that bone defects are almost everywhere. So the current trend is to augment the classic arthroscopic backward repair with soft tissue procedures in order to have lower recurrence rate and better outcomes. Remplisas is one of them. It's a French word meaning fill-in, and it's due to it was introduced by Eugene Wolff, and it is a capsulomyotenodesis of the posterior capsule and the infraspinatus tendon inside the Hill-Sachs lesion. As far as the indication of Remplisas are concerned, Pascal Ballot has the better recurrence rate reported in the literature, because he has as indication the isolated humeral bone defects. However, this procedure is indicated for combined bone defects. And from the early years of the Remplisas, the concept of the engaging Hill-Sachs lesion, and many years after, the concept of glenoid tract and the on-track off-track lesions, prove that it is the combination of the lesions and not each lesion separately. And we try to find which is the critical bone loss, which is the percent that we change our concept from the soft tissue procedures to bony procedures. And we have the critical size of 25%, the subcritical size of 13.5%, and as time goes by, this percentage is lowering and lowering. And from the humeral size, there are several classification systems for measuring the Hill-Sachs lesion, but it seems that the same lesion can be engaged or not engaged depending on the glenoid bone loss. Our experience has been published in KSTA, and we have studied 65 patients that were operated for recurrent anterior shoulder instability with classic backhand repair and Remplisas, 56 men and 9 women, average age of 30 years old, and we follow up them for an average of 8 years. Our recurrence rate was 5.6%, and the rest of the patients were satisfied with the surgical result, returned to their previous everyday activities, and 70% returned to sporting activities without restrictions. The shoulder function was improved significantly, and the shoulder mobility was not affected significantly. There was slight restrictions without, however, affect the activities of the patients. And if we see the literature, there are multiple clinical studies and systematic reviews that show the low recurrence rate, the minimal motion loss, and the very low complication rate of this procedure. The question is this augmentation effective? And this is a comparison between patients managed by bank and repair alone or by bank and repair and remplissage, and the group of bank and repair has a 26% of recurrence, and the group of bank and repair plus remplissage has had 5% of recurrence. This was significantly statistically significant. And this is a cadaveric study, shows that the bank and repair alone did not prevent the engagement in any shoulder with off-track Hill-Sachs lesion, but adding the remplissage, the engagement was prevented in every shoulder previously engaged. Is this augmentation safe? This is a systematic review containing 18 clinical studies and 10 biomechanical studies, showing that the complication rate of this procedure is 0.4%. And as far as the technique is concerned, we try to promote the healing by using the saver and by making some holes in the within the Hill-Sachs lesion, and then we implant one medial and one lateral anchors inside the Hill-Sachs lesion, and then we pass the sutures from the posterior capsule and the infraspinatus tendon, and we tie the knots, having the result shown in the right picture, which the posterior capsule is closed in the Hill-Sachs lesion. This is a non-anatomical procedure, and concerns has been raised about the development of osteoarthritis. So we try to study our previous group of patients, and we find 41 patients, 68.3% of the total, average age 38.9 years old, and we follow up them for more than 10 years. Our percentage is not excellent, however, is decent, concerning that these patients has been operated 10 years earlier. We evaluate the X-rays of their operated and non-operated shoulder with the Samensol-Priestro classification modified by Allen, and with the Kellgren and Lawrence classification. The difference between the arthritis in the operated and the non-operated shoulder was minimal, and there was 24.4% of patients that has been developed moderate to severe osteoarthritis in their operated shoulder. However, 6 out of 10 cases were revised cases that they have already developed osteoarthritis in they develop degenerative changes in during the operation, and 2 of them has developed osteoarthritis to the contralateral shoulder also. So, removing these cases, there are radiological evidence of moderate to severe osteoarthritis after a decade of bank and repair and remplissage is 9.8%. However, none of the patients has had complaints that may indicate development of osteoarthritis. So the take-home message is that the remplissage is a safe procedure and effective and valuable in the long term, reducing the recurrence rate and improving the outcomes. Anyone that performs shoulder instability cases should be familiar with this technique and consider to use it when the situation dictates, and there is no patients to complain for osteoarthritis development after 10 years postoperatively. However, there is 10% of them that have radiological evidence of the degenerative lesions. Don't forget to join ESA, the section of ESCA for the shoulder. I invite you to the next Athens shoulder course next year in Athens, and until then, you are invited to participate in our shoulder discussions every third Thursday of every month. We have two charismatic surgeons and discuss about shoulder things. Thank you for your attention.
Thank you, Manos, for your presentation and, of course, for your help for organizing this event. Let's go on with the results from our live voting. Let's see what you've answered. And we see that most of the people here, 62%, would go for remplissage and 50% for none. That's really interesting. But Sergio, you can go on and take the lead and go on and moderate.
Sure. So Manos, so there are very specific questions that I'm gonna do it now, which are very common in people who wanna learn this technique. So the first one is, how many anchors do you have to put in the heel sacks if only one is enough, or if you have to put two? Okay, and which one to tie first, the remplissage knots or the Bankart knots? These are very practical points that young orthopedic surgeons, they have to understand.
I use mostly, in most cases, two anchors, one medial, one lateral, and it seems that it's better than one anchor that I used in the beginning. And as far as the tie of the knots, I pass the sutures for Bankart repair, but I don't tie them. And then I do the remplissage. And in the end, I return and tie the knots for the Bankart repair. And I add the additional anchors that they are needed.
Okay, and another point is this: do you do this procedure in lateral decubitus or in beach chair position?
I did it. I do this procedure at lateral decubitus because my mentor taught me like this.
Yes, sure.
But I think that it is feasible to do it also in beach chair.
Okay, and one final point would be this: we have been listening to the other moderators about specific position to do the subscapularis augmentation, specific positions of the arm in the moment you tie the knot. So having said that, do you have any specific position when tying the knots of the remplissage, or that's not, or this is not an issue, I would say, and you would do that in the standard position in the lateral decubitus?
No, I do it in the standard position in lateral decubitus, but having the arm in 30 degrees of abduction and the full external rotation.
Full external rotation. Okay, and my last question is, even because of time, when we consider the typical rehabilitation of a standard arthroscopic Bankart procedure, your rehabilitation is exactly the same, or because of the bipolar fixation, maybe you would allow earlier mobilization? So in other words, how do you conduct the post-op rehabilitation of this surgery, of this procedure?
The first three weeks, I use a sling. However, I leave the patients to do some everyday movement, depending on the confidence and the convenience that it has. So I don't have a major restriction to patients with remplissage. And okay, after 3 weeks, I start the passive movement and go into active assisted and active, depending on the progress of the patients.
Perfect. Thank you, Manos, and thank you, Sergio, for your lively discussion and presentation. So we're moving to the next lecture presented by Giuseppe Milano, and we're looking forward to the labral augmentation with collagen matrix scaffold in anterior instability. Thank you. Before we do that, we have our live voting, and this is just a question we want to ask our listeners if they're using labral augmentation in their clinical practice. So just answer yes or no, and then we'll see what our followers are doing. Giuseppe, you're on.
This is Giuseppe Milano from Brescia, Italy. My talk is on labral augmentation with collagen matrix scaffold. This is my disclosure of conflict of interest. Causes of failure of instability repair can be new trauma, technical errors, but most of the cases are related to underestimated conditions like glenoid bone defects, humeral head bone defects, but also problems related to soft tissues. Some predisposing factors like generalized laxity or capsule insufficiency are sometimes underestimated, but also loss of glenoid concavity has been recognized recently as a cause of failure of instability repair. Loss of glenoid concavity can be related to flattening of the bony glenoid cavity, as demonstrated by some studies by Philippe Moroder, but also due to cartilage loss of the glenoid rim, and finally to labral attenuation or insufficiency due to trauma or hypoplasia. So the rationale of labral augmentation consists of obtaining a valid bumper effect, deepening the glenoid cavity and increasing the contact surface area, so improving the action of passive restraints against abnormal anterior translation of the humeral head. So indications to labral augmentations are glenoid labral disruption or insufficiency, as I said, related to traumatic conditions or hypoplastic abnormality of the anterior labrum, or a shallow glenoid, or a combination of both conditions. The surgical technique after a confirmation of insufficiency of the anterior glenoid labrum consists of preparing first step the graft, which is obtained by an extracellular dermal matrix of porcine dermis. The size is established by measuring the length of the glenoid, and then we prepare the correct size of our membrane. The width is usually 2 centimeters in order to obtain a rolled up configuration of our graft of 5 millimeters in diameter. The graft is fixed with 2 zero-braided sutures along its length and 2 monofilament sutures, traction sutures at both ends. After measuring the length of our graft, we start preparing the anterior side of the glenoid in a standard fashion for a Bankart repair. So abrasion of the glenoid neck with a motorized instrument, mobilization of the capsulolabral complex in order to repair and retensioning. Then the scaffold is anchored at the most inferior aspect of the anterior capsule and is shuttled inside the joint and fixed together with the capsule to the glenoid rim with suture anchors. This is a video of the technique, a short video. You see an ALPSA lesion with the disruption, severe disruption of the glenoid labrum with some divot on the glenoid rim. So after measuring the size of the glenoid length, a traction suture is passed through the anterior-inferior capsule to pull the graft inside the joint. Then the graft is maintained in place with the grasper and fixed together with the capsule to the glenoid rim with suture anchors. I use knotless peak suture anchors. Then the sutures are cut and repair is continued from the inferior part to the superior part. 3 to 4 sutures are enough to fix the graft, and you see the good bumper effect. The capsule is repaired just over the graft to improve synovialization of the graft. Enrico Gervasi published a similar technique some years ago to treat multidirectional instability by reconstructing the labrum anterior, inferior, and posteriorly. Here, I present our results of anterior repair or reconstruction with this technique at a minimum 3-year follow-up. This case here consists of 20 patients. We had a complete follow-up of all the case series, and we had one recurrence, so 5% recurrence rate, which is pretty low, and no intraoperative and postoperative complications were reported. Results showed a significant improvement of all patient-reported outcomes. RO score, DASH score, WOSI score significantly improved from baseline. Also, an imaging study was performed at follow-up to be compared with the preoperative ones, and we observed a good integration of the membrane in all cases to the surrounding soft tissue and to the anterior glenoid rim as well, with the restoration of the normal profile of the anterior labrum in terms of height and width. So in conclusion, this technique is a safe and effective procedure. No adverse reactions were observed, and we obtained a good restoration of joint stability from a subjective and objective standpoint with a good integration to the surrounding tissues. Future directions on the use of this technique, we actually are using the labral augmentation technique for cases of revision surgery, specifically with a strict indication to cases with no critical bone defects, labral insufficiency, and eventually associated to a multidirectional instability. But also alternative grafts have been investigated, like the use of gracilis tendon, as you can see in this picture on the inferior right corner of the slide. Thank you for your attention.
Grazie Giuseppe, and thank you for your presentation. So back to the live voting. Have you ever used labral augmentation in your clinical practice? Let's see. Oh, there are a few, 18% of our followers are using this technique and 82 still not. So maybe after this presentation, we have some more to try this new technique. I'm giving over my moderation to Sergio, and we're looking forward to your questions.
Okay, so as we can see, Doctor, this is quite new, at least for the vast majority of us. 82% of the live audience have not done it, and I include myself in that. So my question would be, do you do this for every standard Bankart in which we would do a standard Bankart on a regular basis, or which would be your clear indications for the usual cases in the office when we have no bony defects? We would really like to understand the indications for the common Bankart tears that we see in daily practice.
Thank you, Sergio. Thank you for this question, because you're giving me the opportunity to clarify this issue, very important issue. So basically, I have availability of this patch graft in my OR always. But my indication is pretty strict. I try to accomplish a standard arthroscopic buccal repair by reattaching the labrum, mobilize the labrum and the capsule, and try to reattach. But sometimes the Alps lesion is a scarred tissue, and when you try to mobilize it, it's either thinned, it's degenerated, it's frayed. So there's no consistency. So bumper effect is obtained by plication of the capsule. So I asked myself, why don't add a new labrum and to use the capsule just to plicate, just to reduce the volume and not to create a new labrum, because the capsule is not the labrum in terms of histological features. So the indication is just related to insufficiency of the labrum. The other point is if I see, as I said in my presentation, a shallow glenoid on the CT scan investigation prior to surgery. If I have a very flat glenoid, and most of the times this is associated with a multidirectional laxity, I used to increase the depth of the glenoid by adding this kind of scaffold. If
okay, so just...
If the instability is a multidirectional instability, okay, reconstruction includes inferior and posterior aspect.
Okay, my last point is, I'm going to be very fast. As I am understanding, considering that you have this device on your OR all of the time, do you think that the indication by your answer to do this procedure is not only pre-op, but you do an intra-op evaluation to indicate or not the use of the graft?
Absolutely, yes.
Okay.
So confirmation is intraoperative.
Okay, okay, good.
Thank you, both of you. Thank you, both of you. We have to proceed because we're running out of time, but we can have our questions at the end anyway. So we go on with Philippe Valenti with bony Latarze procedures, my technique. Before that, of course, we have the live voting, and the question here is, what are the contraindications of the Latarze procedure? So go on and vote, and Philippe, you can proceed with your presentation.
Thanks for your kind invitation. My topic is to report the bony Latarze procedure. This is my disclosure. This technique was described first in 1954 by Michel Latarze for recurrent anterior dislocation. It was an open technique on the fixation with one screw. In 1980, Didier Pat explained very clearly the triple blocking effect of the Latarze: bone block effect, retensioning of the anterior capsule, and brachial of the conjoint tendon and subscapularis. And Gilles Walsh in 1991 popularized this technique, and he describes the horizontal split of the subscapularis and the fixation of the bone block with two malleolar screws. In 2007, Laurent Lafosse reported the same technique but by arthroscopy. Pascal Boileau in the same year reported the Bristol Latarze and in standing position with fixation of the tip of the coracoid process with one screw, and he reported the results of his technique with one cannulated screw in 2010. But the problem of the screw is a high rate of revision, 6 to 16%, because there is a risk of subscapularis lesion, fracture of the coracoid process, avulsion of the graft, and many times the screw is too long or too oblique, and risk of pull out the Latarze, the coracoid process. So Pascal Boileau reported the experience of cortical button, and we think that cortical button is a good alternative to screw fixation. He used a small bone block and he fixed with a one cortical button. In 2018, we described the technique with two cortical buttons for the fixation of the coracoid bone block in Arthroscopy Journal, and we started this technique in 2013. So regarding this technique that I continue to use today, I use 2 cortical button fixation with a specific glenoid guide, a specific coracoid guide, because we think that in 2D dimension with arthroscopy, the guide is very useful to optimize the positioning of the coracoid process. So regarding the cortical button system, this is a self-locking device. There is no nuts, there is no prod hardware. We didn't remove any button and no risk of bone fracture. So we prefer to use 2 cortical buttons when the coracoid process is more than 2 centimeters, because it's more stable, less rotation. So with this technique, it's not necessary to use a medial portal, as is necessary to use it with the screw if you want to be parallel to the glenoid joint. So this is a short video to show you how we do with 2 cortical buttons for the fixation. It's important to remember the positioning of the axillary nerve on the musculocutaneous nerve. We prepare first the anterior glenoid rim with a rasper to be flat. And after we prepare the inferior part of the coracoid process with a rasper. And sometimes it's difficult because the shape is very variable. And after we do a split of the subscapularis with a spreader, and you introduce the specific glenoid guide from posterior to anterior to drill 2 tunnels, size 2.9 for the glenoid. And with a specific coracoid guide, we do 2 tunnels. And after, with a system of shutter relay, and we use PDS for the glenoid and the coracoid process, and we pull the 2 underbutton, and we fix the underbutton over the top of the coracoid process before to cut it. And after, with this system, is very easy to guide. It's like a guide, and you pull from posterior the 2 on the button, and we fix with a stable fixation the coracoid process. So this is a true life. Arthroscope posteriorly, Viper anteriorly. We use 4 portals. We detach the labrum and we detach the capsule to see the subscapularis. We remove soft tissue on the rotator interval, and we remove the fatty tissue just below the coracoid process. We prepare the inferior part of the coracoid process with the Viper. We cut the muscle part of the pectoralis minor. And after, you create a space just below the deltoid. We cut the AC ligament. We respect the congenital tendon, and we prepare the coracoid process superiorly, inferiorly, and laterally. Take care between the subscapularis and the congenital tendon, because there is an axillary nerve. So I continue to prepare the anterior rim of the glenoid. I see very well the subscapularis, and I will tag the capsule on the anterior inferior ligament with a lasso loop. So we cut the pectoralis minor medial to the coracoid process. Take care to the brachial plexus, which is medially, like that. I respect the coracoid-clavicular ligament. With a burr, I prepare the inferior part of the coracoid process, and this is the difficulty of this operation. But we have to be flat to have a good matching with the anterior glenoid rim. With a specific glenoid guide, a coracoid guide, we do 2 holes, size 2.9. We finish the preparation of the anterior glenoid rim, and with a specific glenoid guide from posterior. You do a capsulotomy and you introduce the posterior glenoid guide to perform the 2 tunnels from posterior to anterior, and we stop just in front of the subscapularis to avoid any lesion of the axillary nerve. So with a spreader, we do a split of the subscapularis, like that, to look for the 2 drills. This is the axillary nerve medially. Take care. It's superficial to the subscapularis. And with a system of a shuttle relay, we pass on the button from posterior to anterior with the PDS. And after we fix the 2 on the button to the coracoid process, and we cut the coracoid process, and we push from posterior to anterior to applicate the coracoid process over the glenoid rim. And we have a very nice fixation, very stable fixation. We finish this operation with a bankard procedure, and we repair the capsule and the labrum with 2 lasso loop, and the bone is extra-articular. And this is a control X-rays. So this is a reporting of the rate of healing with this technique of full arthroscopy is between 88 to 95%. The recurrent dislocation is the same rate that open Latarjet, and the revision surgery is between 0 to 5%. So we know that there is no neurological complication in our series. There is no hardware, and there is a good healing bone and a remodeling of the bone after 6 to 9 months. So the main difficulty of the full arthroscopic Latarjet is to match anterior glenoid rim and inferior coracoid process to obtain a bone healing and no resorption. It's the reason why, if you use a small bone block as described with Pascal with 1 on the button, the rate of healing is higher. And we propose, if you use a big bone block and you have difficulty because the shape of the coracoid process is not very clear, you can prepare the coracoid process outside with the anterior portal. This is assisted arthroscopy Latarjet. We did this technique 15 cases with 100% healing, no infection, no nerve palsy, no recurrent dislocation. So in my practice, I have 2 indications. 2 buttons if you have a glenoid bone erosion more than 10%, a big Hill-Sachs lesion, an engaging lesion in abduction external rotation with a trachon. So if we have a small bony lesion, if you want to augment a bankard repair, particularly in contact sports, or if young athlete after 10 dislocation, we use a small bone block with 1 on the button to obtain a sling effect. So this is a result of some cases with a good integration and good positioning of the bone block. So the conclusion is that I continue to do arthroscopic Latarjet with a cortical button fixation. I try to use 1 or 2 buttons, depends on the size of the lack of bone on the side of the coracoid process. Less postoperative pain in my experience, less trauma to the subscapularis, no scare. But the learning curve is 50 cases because it's a difficult technique, and I take 1 hour 30 minutes for this operation. So the recurrent dislocation is 0 to 3%, the revision surgery 0 to 5%. And the healing bone progress, and it's important to do a CT scan after 6 months to evaluate the healing, and we have less complication with cortical bone versus screw. Thank you a lot for your attention, and I invite you to participate to the Global Shoulder Arthroplasty 24 online 9 July. Thank you for your attention.
Thank you very much, Philippe, for your detailed presentation. Let's go on now with the results of our live voting. and we can see that 45% of our friends have actually answered multi-directional instability would be the contraindication. So we go on with Sergio, who's gonna ask now his questions. Sergio.
Okay, so Philippe, I have a very specific question to you. The thing is, all of us have already had all around the world problems with screw loosening, as you have mentioned it, in open or arthroscopic Bankart, which would not happen in your case because you have just bone-to-bone contact and no screws in between. So having said that, have you, Philippe, completely given up doing Latarjet open or arthroscopic with screws? And what about your index of complications with screw loosening, as you have said, because this is a problem all around the world?
Yes, thank you, Sergio. Sorry for the video because I don't understand what happens. I sent 2 times the video, it's not incorporated in the slide. I don't know why, but for your question, I definitively stopped in 2013 the screw. Because in my experience, I have the complication of the screw, and it's not the problem of open of arthroscopy, it's the problem of the screw. And I think that with the under button, I have to remove under button. This is a small material. This is extra-articular because I do a Bankart procedure, and I think that is important that the bone is not in the joint, but there is a Bankart to protect the bone. And the hardware, never I have to remove that. And I think that is, for example, in Eden Ibinet, when I do a revision of Latarjet for failure open Latarjet, if you use the under button, you have more possibilities to fix the new bone graft. It's simple. You can go through the rotator interval, and it's easier by arthroscopy to put the bone graft for the revision of Latarjet by screw. Because sometimes it's impossible to remove the screw, but the screw is bent, and it's not possible to remove the screw. It's terrible that.
Yeah, just one final question. I revised 2 failed Latarjets to do an open head and Ibinetti, and I couldn't remove the screws because they were so deep that it was a mess, and I was really afraid of the neurovascular structures over there. So having said that, as you have mentioned, this is my last question. If you have to revise a failed Latarjet to a head and Ibinetti, do you think it's possible to do the head and Ibinetti with buttons and not with screws?
Yes, I prefer to revise failure Latarjet with on the button. It's simple for me. And if it's not possible to remove the screw, I leave the screw like that, and I put on the button. It's simple. And I think that when you do revision of failure Latarjet, for me, arthroscopy is easier if we compare with open, because you know that you stay close to the subscapularis, you don't go inside the conjunct tendon, and there is no risky for the axial nerve. I think that the nerve complication for me, in my experience, is not more important is arthroscopy technique, is less important in my experience than open.
Okay, and well, just 10 seconds. Do you think that considering the amount of fibrotic tissue on a failed Latarjet, there is still space for an arthroscopic revision to a head and Ibinetti because there is so much fibrotic tissue? It's already difficult in open on an open basis. So arthroscopically, do you think it's still feasible?
Yes, I sent a paper to Arthroscopy Journal and is in press regarding 18 cases of Eden Ibinet by arthroscopy, and we have 70 cases of good healing of the bone. I think that with arthroscopy, you can do arthrolysis, you can remove the soft tissue, you can remove adherences, and after you put the iliac wrist bone graft. I think that it's very possible for me.
Very good. I don't know if we have time for more questions.
So
Thank you, Sergio.
I guess not. Yeah, okay.
So thank you very much for the both of you. So we are heading now to our Q&As, and we want to incorporate our participants and followers into our live event. So we have a couple of questions which came in during the presentation. So maybe we start with the first questions, and the one would be regarding Philippe. When performing the DAS, how do you measure the final tension of the long head of the biceps? Is there a measurement, or is there a desired effect of measurement?
Thank you. This is a very good question. In fact, when we did the biomechanical studies, we found that if you want to keep to be isometric, you need to put 20 millimeters into the glenoid. When you put 20 millimeters into the glenoid, you are isometric.
Very short question, but this is the questions we need. And regarding another biomechanical question or tensioning question.
Exactly. Actually, it's a similar question for both techniques. Actually, the question is for Marco and Philippe at the same time. It's regarding the tension. What kind of tension do you give when you do either an ASA or a DAS? And I think that has to do with the position of the arm. It depends actually in the ASA end. How much tension, how do you actually measure it in the DAS?
So what you need to understand or to keep in mind is the DAS works because you put the inferior subscap lower. It's not, the problem is not the biceps. I don't think it works thanks to the biceps. It works thanks to the new position of your inferior subscap. We know that in France for many years, because I don't know if you know the technique of trillia. The trillia, you put all the subscap lower, and it used to work very well. So that's why it's probably not necessary to put all the subscap lower, but just the inferior part of the subscap, the middle, or half the inferior third, and you just need to keep in mind the problem of biceps, but the problem that your goal is to put the inferior subscap lower.
Oh, what would you say? How would you measure the tension actually? How do you evaluate your tension?
You don't need to evaluate the tension. You just put the biceps into the hole, you put your screw, and after you move back outside of the joint, and you see very well your inferior subscap with lower.
The question was as well. Oh, sorry. Sorry, you can go on. Sorry.
It's my turn to answer. Yes, we do the procedure with the arm in neutral rotation. But we have to remember that we are dealing with a subscap that is, as I told, is lax in its upper border. So we lift up the subscapularis tendon, and so you have to close a little the interval, retention the coracohumeral band that attaches to the subscap.
Well. Thank you. So maybe we go on to the next question. Since Hiro already left us because of being very late in Japan, maybe I can ask this question to the panel. And I don't know who of you is doing the SUGAYA technique or something similar. So have you had capsular stiffness problems after doing soft tissue Bankert repair and gap closure and remplissage? How is your post-op rehab program? Maybe we can start with Manos. Like, do you see this in your patients?
What do you mean? What I see in my patients?
I mean, do you see stiffness in patient when you do Bankert repair and remplissage?
Only in the initial stage of the rehabilitation, no, I don't have this complication. I don't have stiffness, only the initial phases.
And Daniel, what is your opinion?
I have the same feeling. I perform open banca repair, labral repair, rotator interval crusher, and capsule application, but we perform that procedure in 20 degrees of abduction and 20 degrees of external rotation. We do not perform those procedures in neutral position. So this gives us the chance to have a better recovery of the range of motion.
We have another question from Professor Marcos Rassi to Philippe Valenti. Is that what do you think about arthroscopic tibial distal allograft for bone defect?
I have not the experience of tibial bone allograft, but there is a new publication regarding allograft with more than 80% of osteolysis on resorption. And I think that allograft is not a good way for Latarjet.
Maybe a question from my side is, do you actually combine two augmentation techniques, for example, either Asa and remplissage, or a DAS and remplissage, or even actually the Hiro just mentioned it, he combines remplissage and closure of the interval. But what about DAS and Asa, and in which cases?
I've never done competition of the two techniques. I think that if you do that, you do the two techniques together, like remplissage and Asa, you can have a stiff shoulder.
Stiff shoulder, okay.
Mm-hmm. What about you, Philippe, with DAS and remplissage?
Same. I don't do remplissage anymore because I have had some lack of external rotation, and I've seen the patients were painful. My patients were painful, and I have had 2 or 3 fatty infiltration of the infraspinatus after remplissage. So I don't do that anymore.
Manos, you had some experience though, isn't it?
Yes, I have performed some cases with Asa and remplissage, and I never have experienced a stiffness. This was a very lax patients, and maybe this is the reason, but I never have a stiffness that deteriorates patients. However, last month I did a revision of a failed back and repair, which is the Hill-Sachs lesion has been not addressed in the first surgery, so I did remplissage, and there was an insufficiency of the anterior capsule. So I perform Asa too.
So from this point, we want to thank everyone watching our event today. And I want to give over the moderation back to Daniel and Sergio to summarize our key takeaways. And maybe Daniel, you can start and then give over to Sergio.
Well, just to say that we have seen different techniques being developed to treat glenohumeral instability, and that shows us that the most popular techniques used nowadays, that are arthroscopic banca repair and Latarjet procedure, clearly cannot address all the cases. There are some cases in between the two techniques, and we have seen, besides that the banca lesion, the rotator interval, the capsular laxity, and bone defects must be considered in one way, or and repair or be reconstructed. And that time will tell us which technique will be massively used and will demonstrate that can fill that gap between the arthroscopic techniques that we have seen, the banca repair, that have been insufficient for some cases, and the Latarjet technique that seems too much for some other cases. So our problem now is to get the best procedure for those patients in between.
Well, just to conclude, it's very difficult for me, Sergio, not to state the same points, but the beauty, I would say all of this that Dr. Daniel has very nicely said, but the beauty is that what we've been witnessing in this lovely webinar is that we have many choices that we can do in between a standard Bankart open and or arthroscopic and an arthroscopic Latarjet. This is nice, and time will tell us, as Dr. Daniel has said, what would be the outcomes in big follow-ups. But meanwhile, we have now new tools to deal with the in-between cases, and this is the biggest message of this lecture. So this can open our minds in the in-between cases, and this is the future for sure.
Thank you for summarizing all the input we got from this sensational presentations. From our standpoint here from Munich, we want to thank our followers. We want to thank the faculty and for your time on a Saturday afternoon in Europe, or late in India, or in the morning in South America. We hope you have a nice weekend. Enjoy the rest of the weekend, and we hope to have you back for one or another event on Wingate event. Thank you very much.
Thank you very much.